Hello, everybody. Thank you for joining us for the 5th session of CHI's Patient and Public Engagement Lunchtime Learning Series. I'm Trish Roach. I'm a knowledge broker here at the Center for Healthcare Innovation. I work both in patient engagement and knowledge translation. And today I'm going to be sharing some info and tools on budgeting for patient and public engagement in health research. First of all, I'd like to acknowledge that we are here on Treaty 1 land, home of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and the homeland of the Métis Nation. We respect the treaties that were made on these territories. We acknowledge the harms and mistakes of the past. We recognize the ongoing present-day colonial violence, and we dedicate ourselves to move forward in the spirit of reconciliation and collaboration. So by the end of this talk, what I'm hoping you'll be able to take out of it is to be able to describe some of the major challenges we face when planning patient engagement, describe the key considerations when you're building a budget for patient engagement, and develop at least a draft budget for patient engagement strategy for health research. We are accredited by the Royal College of Physicians and Surgeons of Canada, working on accreditation with other bodies as well. But so I do have to disclose that I am an employee of CHI, but I have no other potential conflicts to share. So often we talk about barriers to engagement. And so what do we mean when we say barriers? These are not just things like transportation, childcare, or physical barriers, but those processes and systems within society and institutions that we work in that might prevent patient and public partners from being able to fully and meaningfully participate in health research. And so we've done parts of this talk in different forums. Last was at Knowledge Translation Canada back in June here in Winnipeg. And we usually frame it in terms of barriers that patient partners face when coming to engage with us in research. However, in response to someone sharing a list of barriers on Twitter, which was awesome, we had a patient partner point out to us that we're still, in framing it that way, putting the barriers and the responsibility and the onus on patients. And so even though we're asking research teams to consider these barriers, it's still not fair to make them a patient's barriers, right? So instead of giving a list of barriers, I think it would be helpful to talk about some of the assumptions we make when we come into engaging patients and the public in research. So one is, we're so used to working in the research or the policy world, and I'm guilty of this. We begin to assume that what we know and the terms we use every day are common knowledge. So we get stuck using technical jargon, using acronyms like CHI and SPOR and POR and PE and KT and so on and so forth, or other alienating language, even when we're recruiting for involvement. Oops, that's not what I meant to do. Another issue we often run into is how ambiguous terms can be, things we think we're all on the same page about. So if I say the word research in this room, we probably be all pretty much on the same page, be able to know what each other is talking about. But that's not necessarily the case for somebody who doesn't work in this field, who's not in this world on a day-to-day basis, right? Particularly terms like when we compare patient engagement and participant in a research project, where a patient partner who's engaged in the research, they're usually compensated, they should be compensated, but they're actually involved in research decision-making. Whereas when we talk about a participant, they're someone who data is being collected about. They're not making research decisions. So making sure we're really clear about those distinctions. Another assumption, we know people with lived experience that are able to enrich and really improve our research can come from different backgrounds, and they might appreciate different forms of evidence and different ways of knowing than we're used to. We have to acknowledge that we don't have all the answers. We have to be open, we have to be flexible, and recognizing that our way isn't the only way to do things, isn't the only way to do research, and isn't necessarily the best way. Some things I know myself, because of my privilege, I take for granted. Unlimited access to research articles, the internet, computer, printer, meeting materials, food, water, mental and physical health supports, a reliable vehicle, a credit card, peace and quiet. So these are things I don't have to think about on a daily basis, but they can be really big stressors for other people, right, who aren't in the same situation. So it's kind of checking that and recognizing that we're blinded to some of these things. We don't see these stresses. Also, I have the privilege and the courage to be able to ask for what I want and what I need without being treated differently, without being talked down to, without feeling like a burden, without having to jump through many, many hoops. So we really need to work to remove these barriers up front and make the situation more of the same for patient partners, right? So they don't have to jump through hoops or, you know, for example, we can simply say things like costs will be reimbursed or supports will be provided as needed. And that way, we're still putting the onus on patient partners to have to ask for what they need to be fully and meaningfully involved. We want to make sure we're getting up ahead in front of that as much as possible, right? So it's about talking to them, figuring out what their needs are before we start to engage and offering those things up front, not making people feel like it's a burden and that they have to ask for what they need. And of course, we would love for engagement to be easy and painless and quick and conflict-free, but it's about building trusting relationships. And every one of us has been in a relationship, and I'm sure every one of them has had lumps and bumps and challenges that we have to get through. So as long as we're working together towards a common goal for research, I think that's really what we can focus on to move things forward. So instead of 7 slides of a list of barriers, I do want to list some key considerations to focus on with that equity perspective. So when we're recruiting, thinking about if we're recruiting in English, people are going to assume that the engagement activity is in English. Even if we know that we're willing to provide translation or interpretation supports, we need to really make that clear. Also, people who might not regularly access health services. So thinking about where we recruit. If we're using clinics, doctors' offices, people who face additional systemic barriers, people who might be struggling with mental health issues or substance abuse issues, might not have access to those same resources and so don't have the same opportunity to be involved. So we need to think about ways to go out and meet people where they're at. People commit their time and energy because they believe there is value in their involvement in research. So we need to really consider the day-to-day needs of their lives, not just physical accessibility, but also safety of a setting. So taking a trauma-informed approach and considering locations such as a hospital or an institution may actually have those experiential knowledge that we're looking for intertwined with experiences of trauma. So recognizing that's a possibility. Capacity for involvement, not just of patient partners. Obviously, we want them to be able to contribute to research and have the knowledge and skills that they need to feel like they can fully and meaningfully be involved. But we also have to think about the capacity of researchers to engage. So maybe that's soft skills, doing an internal and external assessment of our readiness to engage, how flexible are we, and those kind of things. And then the social and historical context, depending who you're working with. You know, we know there's power dynamics between obviously clinicians and researchers and many patient partners, but also there might be between patient partners. So there may be patient partners who might silence each other, not intentionally, but thinking about the ways that we can engage to make sure that everybody's voice is heard and valued. So I know I wouldn't give you a list, but because we're talking about budgeting, I'll talk about some of the most common things we see in budgets and that we budget for. Number 1, being food. Even if you're having a short engagement, you know, you don't want people to be hangry, obviously. You want to make people feel comfortable, and food is a really great way we can connect with each other and be made to feel more comfortable and share something together. Parking and transportation, always, again, when we talk about getting ahead of things and not having people have to pay things out of pocket. So if you can get parking passes ahead of time, bus tickets, and providing that kind of accommodation before people need to pay for it, that's ideal. Obviously, if there are documents that need to be used in meetings or workshops, as there almost always are, patient-public partners should not have to worry about printing these. They shouldn't have to worry about bringing their own materials. And also, if you can provide, you know, access to a computer or the internet and those kind of resources that people need to be fully involved. Caregiving, so that includes childminding, particularly if you're doing a project that is focused on pediatrics, right? Thinking about that, but also caregiving if somebody's taking care of an elderly relative or somebody with special needs who needs care on a regular basis. You know, making it clear that you're offering this and we want to help you with this rather than forcing people to have to come and ask for it. And also patient partners who may be able to attend, but not fully participate without a care attendant with them. So, you know, just being mindful of that, depending on who you're working with. And thinking about inclusivity, obviously, we want to provide translation and interpretation wherever it's needed or desired. One of my colleagues who works for WHA, Winnipeg Regional Health Authority, informed me that through them you have access to translators. They do cost, but so depending where you are, your institution might provide those or be able to connect you with them. Payment for elders, counselors, or other supports to attend may also include gifts like tobacco or gifts for speakers. If you're doing a workshop, something like a professional facilitator, especially if there are difficult subjects to discuss. And then if the opportunity arises for patient public partners to attend or even present or co-present at a conference, that is an excellent opportunity. And in that case, obviously providing accommodations, airfare, some per diem upfront is the way to go. And the hot topic I'm sure everybody wants to talk about, compensation. So first, before we kind of dive into that, I want to just make the distinction between compensation and reimbursement. So compensation is when we pay a patient partner for their time, energy, and expertise for engaging in a research project. Reimbursement is when we're covering expenses that they have to incur to participate in the activity. So just making sure we separate those two. So a lot of what I'll share in the next few slides is taken from some resources. So CIHR has draft guidelines for compensation. The SPOR working group has a compensation document. You don't really need to write anything down. I'll send all of you the slides. They have all the links. The slides are available on the event page for those of you online with hyperlinks. So it's all there. Don't have to write anything down. So there's essentially 5 different ways they've categorized that you can compensate patient partners. The most common is a fixed service income. So this is either an hourly rate. The guidelines bare minimum is $25 an hour for patient partners across Canada. That's what we would highly recommend. Or a daily rate, you know, if somebody's going to a workshop for 3 hours, whatever, something like $100 or $300 for a full day course, somewhere in that range. It really depends on what your patient partners prefer, right? So it's about talking to them. Salary or a stipend, this one's not as common and not based on hours. You might have to work with your institution and HR regarding employment. This is, for example, if you wanted a patient partner to be engaged long-term as a co-researcher on a longitudinal study or a longer-term project, I think that would be more appropriate. Honoraria, which I think we're more familiar with, is a voluntary one-time payment for something that you wouldn't usually pay for, so guest speaker or sharing at sharing circles, something along those lines. In-kind payment or gifts. Some patient partners may prefer not to receive cash, you know, so gift cards, perhaps attendance at a workshop or at a course for professional development might be more appropriate, or donation to a charity of their choice, even something like software, like Microsoft Office, as compensation. And then, of course, there's always the option for somebody to opt out or decline depending on their own preferences, their financial circumstances. But ultimately, this really needs to be the decision of the patient partner, and we're just giving them options, right? And trying not to influence. Sure, yeah. So for those all you asked for it. So the question is, so I'm just going to repeat for the mic. The question is if we ask for a social insurance number for all these forms of compensation. No. There are different ways to go about this depending which institution you're at. University of Manitoba in certain situations where we want to keep confidentiality, like we could order gift cards ahead of time or get cash ahead of time, have people sign and have the researcher hang on to that list of people's names where we wouldn't collect SINs, and then we would only have to dive into that if we were audited, right? So there are ways to avoid that. When we generally, with the fixed service income, we do end up collecting social insurance numbers because there are tax implications. So it's a requirement of the institution to have that information. At U of M, it's if anyone makes over $500, they have to provide a T4A slip, and then it's required to be reported as income. So I'm kind of getting into that in the next slide, and I think it's pretty complicated, but hopefully that is helpful. So yeah, giving them this information, the opportunity to explore payments before engaging, contacting your own institutional finance or HR department for specific advice. Because I've done a lot of digging into this, there are potential tax implications. It can really affect someone's income, especially if they're receiving disability or unemployment income. So we really want to try and give them as much information as we can. So I've included a couple of links here for the University of Manitoba if you're looking for help in figuring that out in your own project. For other institutions, I would suggest looking for something similar. Sorry, I didn't do cross Canada, but there are ways for them to offset it, right? Like contributing to an RRSP. I would say in general, I am not an accountant in any way, shape, or form, and I think many of us as researchers aren't, so it's not necessarily appropriate to be providing financial advice to a patient partner about how this will affect their income. But if we can provide resources and supports for that, so for example, there's some links again at the end to the Canada Revenue Agency guidelines for what is taxable income. They also have a search function. Again, I have the link for that because stuff is hard to find on that website. For free or low-cost tax services in the area. Those are generally, you can find more around tax time, so starting soon, right? So yeah, that's kind of the nitty-gritty taxes side of it. I can't give any concrete answers. That's pretty much the nature of that game, right? In terms of systemic barriers, there may be some people engaging who face additional barriers, so it may be appropriate in talking to your patient partners to be paying people in different forms or some more than others. And that's really, you have to have an honest and open conversation about that. But we do recommend to try and keep payment consistent throughout your institution or organization. So we don't want one patient partner on a research project being paid and somebody else not, right? That just is inconsistent. And again, the key take home is discussing those payment options with patient partners, giving them the information well ahead of time so they can, use these resources, figure out how it's going to impact them and their own situation and what they would prefer. And, there's always the option to change things. If something comes up, okay, we have to figure something else out, and working with them to figure that out. I'll take a quick break. Why not? Any questions or comments about that particularly? I know it's yeah, for sure. My name is Kat. Yeah. So it's Kathy Woods from CanSolve CKD. A lot of issues with compensation are, like the patients are facing a lot of issues, being the only ones at the table not being paid. That's what you're saying?
Yeah, and so it's not a question of compensation, also a question of ensuring that everyone,
right?
If you're sitting and having your it somehow helps how that might be helpful.
So using the guidelines ahead of time to talk to patient partners about that there's A option, B option. Okay.
The other part of that may have
Right.
Last year, like I was like, so one of the facts that ability for an act, and I would say my I know from
Yeah.
because I mean, that's the question.
Yeah.
I've already confirmed that all of it. Or not. Maybe prefer telephone one-on-one. The other thing that
Yeah.
you can go into medical home and people that were and worry that
That's incredibly stressful.
who got this
Yeah.
has so worried, and so I went to the hospital. So at Ansel, there, so and while it takes me that
Yeah. So I just want to share that with the people online. Cancel CKD is working so that patient partners has developed a way so that patient partners don't have to have a credit card, especially for things like travel and hotels, airfare and hotels, right? Those are entirely credit card based. So I think you're saying it's communicating with the hotel and being really sure that the researcher in charge is paying for everything up front, ensuring that the hotel's not going to ask for a credit card. And I know we've done this too, where you have to call the hotel and say, okay, so you're charging this credit card ahead of time. You're not going to you're not going to ask them for a credit card, or you're not going to ask them for payment. So yeah, no, I can't imagine how stressful. Well, no, I can. I was a student and I didn't have any money and I had to use my own credit card to travel, and it was a nightmare and I was terrified. Actually, one time I told the hotel, I said, I don't have any money, so would you like me to wash dishes? Right? Like, I don't know. I literally have $20 and I'm not giving it to you, right? So yeah, we have to ensure and be absolutely sure that people don't have to pay out of pocket. And I think it's especially challenging for flights. I know now U of M, there's changes coming. I don't think it's U of M actually. I think it's WestJet, where a credit card is absolutely required at the time when you're checking in. So I mean, it's going to be a heck of a time figuring out how to get around issues like that. But that's what we have to do if we want to, you know, show patient partners that we value and support their involvement. We have to take those extra steps, and it's tricky and it's tough. Thank you for sharing. Can I ask, just for the next person to ask a question, can I get you to use the microphone? Is that okay? I have it. I think, Catherine, did you have a question?
Yeah.
Sure. Okay, great. We're doing the best we can. So,
could you just clarify on the $500? If with U of M, if you $500, you're required to submit a T4A. Is that whether you define it as an honorarium or whether you define it as like?
Oh, we're getting into the nitty gritty. So I'm not 100% sure how it works. Again, I'm not in finance. That's why I gave the link to the finance department. But I know the form that we often use for, I guess you would call it the fixed service income. Generally, that does have a spot for them to put their SIN, and then we do tell them, you know, if it reaches $500, you're going to get a T4A. Like, we'll try and give you these resources, but ultimately CRA sees it as your responsibility to claim this income, right? And it's a crappy situation, but there are ways to try and get around that. I can't speak for every context though, right? And it really depends on who you're working with, what their financial situation is, how much the researcher wants to push back on certain things, right? So I think it's up to the researcher and patient partner to figure out what the patient partner needs and what they prefer, and then the researcher's responsibility really is to push for that and push back when they have to, right? Alex? Thank you so much.
Thank you. I'm just wondering, I think my question is mainly to you or Trish. Do patient partners, does their compensation change over time? You mentioned that yours did, your needs, but would all patient partners be expected to be receiving like the same income, or would some have a different salary or compensation than others? Like, would you have raises over time? Things like this.
Feel free to share.
It depends on what if you look at the CIHR website, I believe it's also on the CanSolve website too, but there's a link to the SPOR compensation, and so there is a A and a B that you can you know, check that that's the one that you're going to do, and one of them is actually you know, like I believe there's a one that's like $1,500 for, you know, that's done every 4 months and stuff. And it depends on your level of engagement, how much you're engaged, how many meetings. Within our CanSolve, like, you know, I know patient partners that, like for me, right now this week, I've done about 4 to 6 hours already this week, just on telephone calls, on, you know, different things. So it entirely depends on the patient and what the patient wishes. In terms of, but there are so many out-of-pocket expenses that people don't even think about. Like when you come to an institution like this, I don't know about anybody else, but I just paid $12 to park here, you know, and nobody's compensating me for that. I'm doing this because I'm involved in patient partner research, and I really think it's important. My institution, if I submit this to CanSolve, they will pay me for it because it's part of you know, what I do in terms of ensuring that I am keeping up to date with what's going on out there. And the other thing about the compensation at a senior level is that we have brought this compensation question to the senior people at CIHR. We've had several conversations. Our executive has sent letters to Carrie Barasa, all of those folks, about the compensation to try to figure out, because I mean, really, their government, like, can't they figure it out at a senior level for people that make more than $500? And trust me, if you're getting compensated at a $200 or $150 honorarium, it doesn't take long, you know, and so that's why a lot of people don't claim it. You know, they just don't claim it at all. Like myself and my co-chair, we often talk about our gigs that we do are in effect part-time jobs, because now that I'm retired, it's you know, even more in terms of involvement. But I really think that it has to be addressed at the very beginning. If it's not addressed, then it just kind of becomes a bigger barrier because us as patients, like, we don't want to have to ask people for money. Like, I don't want to have to say to them, I'm going to go do this. Can you, I'm going to put in a half a day honorarium. Can you submit that? So, like, for most of our expenses, it all comes in an expense form, and we don't have to say half a day. We just check the box. We did this, this, and this. We were at this many meetings. This is what we did. And so there are ways for organizations and research ways for them to make it easier. And you talked about the SPORE working group for the
Yes. Evidence Alliance.
Evidence Alliance and that. And so there are a lot of different organizations that are looking at that. But I really believe that it's us as patient networks and us as chronic disease networks, and certainly as the provincial SPORE, to be able to tackle this together. Because there are so many patients. I know so many patients that just will not, because of that, having to give people a social insurance number, they won't go there at all.
Excellent. Okay, I don't think I could have answered that nearly as well. Thank you so much. Okay, I think we're good to move on to some highly practical part of our talk. Going into our third objective, so building a patient engagement budget. So there's different sources for funding patient engagement. I know a lot of grants you're able to. I don't have a list. I can tell you which ones do, which ones don't, but I'll take this chance to plug ours. CHI has, we offer twice a year awards to researchers, students, community organizations in Manitoba who are looking to engage really in the very early stages of research. So that's in designing the research, deciding priorities, research questions, outcomes, and grant development. And so recently we offered 5 awards of 5,000 or 4,000. Sorry, whoa, getting overboard there. And so we'll be announcing those soon. There's a link there if you're a Manitoba researcher, community org student. If you're interested, you can check that out. And the next call will be in a few months in spring 2020. So in response to questions from researchers, from students, from research staff about building a budget, we developed a tool. It started with a quick and dirty online calculator. I think it was calculoid.com or something. I created this just so you can get a really quick look at how much engagement might cost for you. But then we kind of went a bit more in depth, and we have a downloadable budget builder. It's an Excel file. I tried to make it as not intimidating as possible, being that it's in Excel. You can access that through that link. We co-developed this with researchers, other KT and PE practitioners, and patient and public partners, particularly from our Patient and Public Engagement Collaborative Partnership. We continually try to update this based on user feedback. So if something isn't working, if it's not meeting your needs, if it's confusing or super complex, part of why I'm doing this in a talk to help guide you through it, let us know any advice or suggestions. We do provide some guidelines for amounts. These are specific to Manitoba and sometimes Winnipeg, but I think a Google search could help you find something similar depending on where you are. And we did include, also at the request specifically of researchers, a summary table, which is formatted as a one-pager that pops out the numbers at the end. You can pop that into a grant or funding submission, so hopefully that's helpful. And we do have a how-to blog post as well. So I think what I would like to do then is do a quick example with the budgeting tool. So just bear with me, this example is totally made up. So you decided to hold 2 3-hour discussion groups with women with diabetes. You're going to design a clinical trial together. You've talked to the community, some community orgs, some local organizations, recruited 10 women who prefer a Friday evening meeting at a local library, 2 are Indigenous and prefer Cree, 7 require childcare, and 1 takes care of her aunt 24/7. And because you got a prep award, you have $4,000 to do engagement. So we're going to go ahead and plan that. And I'll just show you how to actually access. So just bear with me I'm going to click on this hyperlink. There it is. Oh, good, it works. This will take you to our CHI website. The downloadable tool is here. The rest of the materials are further down the page. This is what we're interested in. Hopefully you have Microsoft Excel or a similar program. Enable editing, first thing you want to do. I've protected these sheets so that you can easily tab through. These white boxes are where you want to enter your information. Follow along the instructions. I know it looks a bit daunting at first, but it's intended to just kind of go through. There's this main budget builder page. That's kind of our home page here. We have other tabs for building compensation, again, based on those guidelines for the different forms. We have some considerations for inclusivity and accessibility, and then we have the one-page summary that you can print out or attach to a grant. So say we're doing, what was it, 2 discussion meetings. We tab through. The next is how long are they going to be in hours? So 3 hours, and we have 10 lovely ladies joining us. So these are really the key parts that will help the file do all the math for you to figure out your amounts for food and everything. So then we'll go down to engagement activity costs. Number 1, compensation, and we can use these blue hyperlinks within the file to flip back and forth between the pages. So now we're in the compensation builder. Gives you a little bit of information at the beginning. We're going to do fixed service income. It's not really, doesn't really matter how you enter it in the spreadsheet, but it does give you the option to do different forms of payment if you're paying people differently or different amounts or they're engaged differently. So we're going to pay all 10 station partners, and we're going to do our recommended $25 per hour. So just make sure when you're using this that you're looking at the question in terms of what is it asking you per hour, per meeting, per person, that kind of thing. If you don't, your numbers will be wacky. We can then use the hyperlink to go back to that main budget builder page. So we've got our compensation done, and these gray boxes will fill in the amounts as you go through, so you can kind of take a look. Refreshments, it's Friday night. We're going to do $20 per person for a nice little dinner for these ladies. We keep going down. Professional facilitator. Yeah, some of the topics, priorities that might come up might be tough, and we want to make sure we capture everything and that the conversation goes well. So we're going to have a facilitator. Their cost is $90 per hour. Support services. So we've talked to those, the women, the Indigenous women would prefer an elder is in attendance. So we're going to have an elder. They've identified an elder for us, and they tell us that they charge $50 an hour for their support and participation. So now we get into communication, and it asks us, do we need an interpreter or a translator? Yes. Again, we can use the hyperlink to go over to the inclusivity sheet. They've told us that one translator is okay for both women, Cree translator, just to make things easier so they can fully and meaningfully participate, right? And the rate for the interpreters is $35 an hour. These are kind of just standard amounts that we've figured out. They might vary slightly. I'm just kind of going with what I am familiar with. It might be different depending on where you are. We know we're going to do some caregiving costs as well. So childcare. I remember this example well because I practiced. It's 7 women. We're really lucky. They all have babysitters, and they're all in their 20s. They're students, so we're giving them $15 an hour. We also know that one takes care of her elderly aunt, so we're going to cover those costs. Respite worker, this one is charging $90 an hour is their wage. We don't have anybody traveling from rural and remote locations, so we can, at any time, go back to the budget builder. We could also, if we want to, kind of see where we're at with the budget. So we're still under $4,000. We're doing okay. Let's keep going through the budget builder. What else do we have to take care of? Okay, we've got caregiving, transportation. You said $12 for parking. We're going to go with it's $15 per person per meeting to cover whether they're, gas mileage or whatever it is, however they're getting there. No patients require the special assisted devices, so we're okay there. And I see we're getting close to the top of our budget, so we're gonna might have to tweak things afterwards, right? The library charges $30 per meeting. We're lucky because we're a nonprofit. AV, we're okay without that. And I just tabbed through transcription. We do want to transcribe that part of the meeting where we're coming up with priorities because we want to make sure we capture everything. So we're going to say that's going to take us 30 minutes. I'm going to go with the low end of transcription, $1.50 per hour. Disposables, okay, we're going to go to Dollarama for pens and stuff, so $5 per meeting. And then you can also add if you have additional meeting costs. These could be gifts for speakers, tobacco, any kind of incidentals per meeting. So I've included that there. Your imagination, whatever that may be, I have no idea, right? But you have that option. You also have the option for one-time costs. So this could be like posters, advertising. This could be a software license, that kind of thing. And then we would highly recommend, because patient and public engagement is iterative, it is dynamic, things change, things happen, we run into challenges. We really recommend a contingency anywhere from the low end of 5% up to 20%, depending on, what your engagement looks like. Are people really traveling a far way? Things can happen. So we're going to pop in 5% for our contingency. And how did I do? Oh, I didn't do too bad. $4,300. So we could play with that a bit. Figure out a way to get another $300 on top of the prep award. But hopefully that's helpful for you to see how that budget building tool can work for you. Hopefully you can use it. Let me know if you have. I'm going to add a feedback link on the page so you can provide any complaints or accolades as is appropriate. Okay, so that's the budget builder. Any major questions, issues? A couple nods and some yes, okay. Okay, great. Excellent, that's what I wanted to hear. Okay, we have a question.
So what if we're doing
Okay, so we have a question. What if we're doing 2 meetings? And the compensation would be different for those essentially, right? Right. You might want to do 2 different budgets at this time. That's what I would suggest. I haven't figured out a way to build that kind of complexity into it. I'm not any kind of programmer. I just have a basic knowledge of Excel. So yeah, in that kind of situation, I would just do 2 separate ones. I wish I could be more helpful. I've got a couple more slides here. Oh, I just want to do another push for our Knowledge Nug blog series. If you are new to patient engagement, you want some more kind of introductory info, we have a PE 101 series, and the link is there. It also has KT tools and resources. And a plug for our next lunchtime learning session, Safe Spaces, Brave Spaces, and Inclusive Engagement. And that'll be on February 12th, 12 to 1 p.m. in this room here and on the same site for our webinar. And as I promised, the resources slide, which I will send to everyone who's signed in. As long as your email address is there, you'll get a copy. Thank you, and let's have more discussion. Yes. Can I give you the mic again? I know you don't like it, but I'm going to make you do it anyway.
I just have one other suggestion in terms of when you talked about the fact that you're going to have a in-person meeting and then maybe a Zoom call.
Yeah.
You can't automatically assume that everyone has a Wi-Fi and has access to a computer, an iPhone, all of these things. So you can't assume that people have that. So you have to make arrangements. So wherever the meeting's being held, you still might have some expenses for, say, 5 out of the 7 to be able to come into and do a face-to-face. All of the work that we've done in terms of patient compensation and patient engagement really points out specifically that we prefer as patients to do a face-to-face, whether that's on Zoom or what it's on. We do a lot of Zoom within our CanSolve CKD, and we find when you're on conference calls that you often take silence as that's okay. And a lot of times, if you could see the look on people's faces, you'd know that that's not okay. And it's also kind of for who's ever facilitating. We always do like around the table or making, and myself as a facilitator, if I'm facilitating or co-leading the meeting, I make sure that I go around and I ask everyone, what do you think about that? And actually to know your people, to be able to say, Thomas, what do you think about that? How do you think that would work? How do you think this would work? And so you really, really have to do that, and you have to make sure that that happens, because a lot of times we assume that people have access and have a phone, have all those things, and it's, especially here in Manitoba, it's not necessarily the case. Like I can go from here to Sandy Bay, and Sandy Bay First Nation, which is about 45 minutes on the other side of Portage Prairie. I can go there, and about halfway up Highway 50, you lose your signal.
Yeah.
It's gone. You can drive around the First Nation, and you might get a signal, and you might, if you have 2 bars, you might try to make a call or try to do something. And so, that's within 2 hours of Winnipeg, and people don't realize that having access to Wi-Fi isn't just going to your local Tim Hortons or wherever. Having access to those services is not necessarily something that everyone has, because a lot of people don't. Thank you, Megwitch.
Even the private, right? Might have access.
And the comment is, even there might not be privacy on a certain Wi-Fi network or in the space that you're in to communicate. Any other questions, comments? I'm running around the room with a mic. I'm sorry I'm doing this to you. I just want our online people to be able to hear everything. Okay.
The CIH considerations, is that the last document that was out? The last 4 competitions?
I hope it's the most recent one. This is it said it was a draft compensation guidelines, so maybe I'll get in touch with you to make sure that it's.
Yeah, well, it's I mean, there's reasons why. Why it's a draft.
Yes,
So,
yeah, reasons it is a draft.
yeah,
Yeah, for sure. I think what's really great on these resources, the Evidence Alliance has a really thorough appreciation policy and procedure that I think takes a lot of those barriers into consideration and tries to make it easier for patient partners for compensation. All right, I hope that has been helpful. Do we have any questions from online? Okay. Okay, well, yeah, so the slides, I'll send them out. They'll be available. Oh, one question. Yeah. Oh, the slide to the title of the next one. Yes, so there we go. So that would be our next lunchtime learning. A warning, if you have attended the lunchtime learning and registered and given me your email, I will invite you to the next one. So thanks everyone for coming. I really appreciate it. I hope it was a helpful discussion, conversation. Look forward to the next one. Thanks.